like to welcome everyone to our program, Uncovering Gene Fusions and Other Key Genomic Alterations in Lung, Thyroid, Colon, Breast, and Other Solid Tumors, to enable patients to gain the full benefits of targeted treatment. Today we've assembled a wonderful group of speakers. I'm Alex Drellon, Chief of the Early Drug Development Service at Memorial Sloan Kettering Cancer Center in New York. And I'll let our other two speakers introduce themselves, starting with Dr. Dimitri.
Thanks, Alex. I'm George Dimitri. I'm a professor at Harvard Medical School, and I direct the Sarcoma Center and co-direct the Ludwig Center at Dana-Farber and Harvard Medical School.
Hi, I'm Vivek Subbiah from the University of Texas, MD Anderson Cancer Center, Houston, Texas. I'm an associate professor here and also the Center Medical Director for the Clinical Center for Targeted Therapy, which is the early phase drug development program at MD Anderson.
We have here our agenda for today. The seminars in oncology are divided into two major sections. The first section will focus on the biology behind fusions that we're going to discuss, where these are found across different cancers, and what tests we can use to find these fusions. And then finally, in the second session, we're going to cover the targeted therapies that are available for the treatment of patients with fusion-positive cancers, how these cancers can acquire resistance to therapy, and what new treatments are available in the setting of acquired resistance. And then we're going to end with a practicum where we're going to talk through a few cases of patients who have responded to therapy and discuss as well strategies for diagnostic testing in the clinic. Before we get into the first session, we'd like to first touch on the gaps that led to the symposium that we have today. Essentially, we would like to highlight that there are therapies that are active for these fusion-positive tumors, as it's a well-known fact that we can do better in terms of diagnostic testing to find these fusions and appropriately match our patients to these targeted treatments. And we begin with the first seminar, and I am going to kick it off. We'd like to start with the history of the discovery of oncogenic fusions for you. And you see here on the upper left that the seminal event was the discovery of the small marker chromosome in patients with CML that we later identified as the BCR-ABL translocation. And if you look at the bottom of the arrow, you see that subsequent to that, a number of fusions were found in many other cancers, specifically solid tumors, where we first found a fusion in a salivary gland adenoma, followed by Ewing sarcoma. But later on, you'll see that many different fusions were found in cancers like lung cancer and gastrointestinal tumors, among other histologies. We'll also note that in the different colored boxes, we've seen diagnostic migration that we'll also touch on in this session, where earlier efforts were focused on assays like karyotyping and chromosomal banding, later moving towards assays like FISH and RT-PCR. And today in 2022, of course, many centers have migrated towards more comprehensive sequencing with NGS. So what is a gene fusion? Essentially, you have, in simple terms, one gene fusing with another, either with the genes being on different chromosomes or the same chromosome. There are many different types of gene fusions, but today we're specifically going to discuss fusions that include a kinase domain that drives oncogenic signaling. And when you're looking at a patient's report, in order to figure out if a fusion is real, some of the buzzwords that I like to remember are that the event is in frame, meaning that it can be read, the message can be read without interruption or skipping of one or two codons. But the second major buzzword is that you have the intact kinase domain, which we mentioned drives signaling and growth of the cancer. While this applies to many fusions like ALK and ROS1, we're going to highlight two different fusions for you today. Here you see RET fusions. These are found in lung and thyroid cancers, and you'll hear more about that in the next section. But the yellow motif there shows you the kinase domain that's typically intact in a RET fusion, and that occurs in the 3' portion, or the end or tail of the fusion, while in the 5' position, the other gene typically can contribute motifs like coiled domains that result in ligand-independent dimerization and constitutive activation of the chimeric oncoprotein. The same is true of NTRK. If you focus your attention to the lower right, again, where you see an in-frame event with a full NTRK kinase domain. But one thing to remember is that there isn't a singular NTRK gene. If you focus on the table here, you'll see that there are 3 different genes, NTRK 1, 2, and 3, that encode the proteins TRK-A, TRK-B, and TRK-C. And with that, we'll pass it on to Dr. Dimitri to talk about where we find these fusions.
Dr. Drillin gave you a very nice history of the overview of fusions in cancers, starting with the original paradigm of the CML-BCR-ABL fusion. But since that time, many people have discovered many other fusions, and I call your attention to this paper by Nico Stransky from 2014, where he looked through many public data sets of gene sequencing and found a number of kinase fusions across many types of cancers. Look on the x-axis. You see fusions in many genes. Those are on the y-axis. But on the x-axis, you see the many different kinds of cancers that have gene fusions identified. Thyroid cancer, glioblastomas, lung cancer, sarcomas, and the list goes on and on. This is the so-called long tail of kinase fusions, which can be found in many types of cancers. So you're getting a theme here that kinase fusions can be found across a range of histiotypes. And it's very important that we as oncologists identify these to try to choose the right therapy and understand what standard treatments do. We certainly know that it's important both in adults and children. On this figure, you see the fact that certain very rare tumor types like infantile fibrosarcoma are defined by fusions, let's say, in the NTRK gene. So that's a very rare cancer, but it's very widely known that more than 95% of them will have the fusion. On the left, in adults, in red, you see the types of rare cancers like secretory breast cancer or the mammary analog secretory carcinoma of salivary glands, which again have NTRK fusions almost all the time, but others like lung cancers and even different types of sarcomas will not necessarily have these TRK fusions all the time, but they're certainly important when they are present in patients. So it's really just important to keep these in mind because it makes a difference in the way we approach our patients. Now, one way of conceptualizing this is where would these fusions be found in most of the patients with a type of disease? So look all the way to the right of this table. You'll see the rare types of cancers I just mentioned, like this MASC, or mammary analog secretory carcinoma of salivary glands, the same type of secretory in a breast, so that's a breast carcinoma of the secretory subset, very rare. And then infantile fibrosarcomas. All of those will have a very high, probably more than 75 to 95% fusion frequency in the NTRK gene. If you go all the way to the left, you see a number of more common cancers like adenocarcinoma of the lung, colorectal cancers, other types of things like rare breast cancer subtypes or glioblastomas. There you'll see a TRK fusion in less than 5% of patients, but even though they're rare, they're absolutely critical to think about in the differential and to consider as a therapeutic target for those patients. And in the middle, you see sort of the middle ground. Where are these somewhat enriched? And I'll call your attention to the bottom group there, GIST without other mutations. So if a GIST does not have a mutation in KIT or PDGF receptor alpha or RAF or something else that's very rare like SDH, those GISTs are where they are enriched for TRK fusions. So again, we can try to find these tumors where they're going to be enriched, but most common cancers will be all the way to the left of this. Unusual, but should be part of your comprehensive genomic profiling for things like lung cancers. Now, similarly, There are RET fusions in a variety of solid tumors that can be found. And the key thing again here is if that fusion is in frame and turns into a fusion oncoprotein, it's almost certainly a driver of that cancer. So most commonly we think of RET fusions as occurring in non-small cell lung cancers. Even though they're rare, non-small cell lung cancer is common, so there are a lot of patients with that. And a higher percentage of patients with papillary or other thyroid cancers, 10 to 20%. Below that, you'll see a number of other common cancers like pancreas cancer, colorectal cancer, ovarian cancer, or even cholangiocarcinoma, which have a low, less than 1%, but still a finite incidence of having RET fusions. And when they are there, they are almost certainly the drivers. So it's very important to keep this in mind as well as you approach patients with a variety of solid tumors.
Now we'll turn over to Dr. Sabaya to talk about the tests that we can use to find these various fusions.
Yeah, now we come to diagnostics. The pace of genomics and immunological breakthroughs in oncology is breathtaking. And the key and the raison d'etre of precision oncology is offering the right drug to the right patient at the right time. Again, Dr. Drillin and Dr. Dimitri have elegantly defined how we detect these fusions and why we need to detect these fusions. Now, the important part comes to the diagnostic aspects. So, what are the different technologies to assess these fusions? Different methods have been used to test for the presence of all these NTRK or RET genomic alterations. Methods available are IHC, which we call it immunohistochemistry, FISH or fluorescent in situ hybridization, RNA and DNA-based next-generation sequencing assay. However, the sensitivity and specificity of all these tests are varied. And like for instance, the sensitivity of immunohistochemistry based technology are not optimal. And IHC has not been viewed as a reliable testing in this setting. So fusions, as you see in the slide, are a different kind of fish. We need to understand, basically the difference between fusion and a mutation. Take for instance in NTRK or RET. So what does the gene fusion do? The gene fusion there is no change to DNA sequence, whereas in a gene mutation there is a definite sequence, there is a definite change in the DNA sequence. And as you can see here, the change to the location of the gene of the chromosome is seen in fusions. Typically, because of these gene fusions, it results in an overactive receptor. For NTRK genes, fusions are activating and predictive of response to targeted therapy. Again, as I said earlier, these fusion events, specifically the RET fusions, are prone to underdetection by FISH. And why we need to do different testing methodologies, right? What we say here is testing for RET fusions is very important, especially for malignancies with high RET fusion prevalence like non-small cell lung cancer, thyroid cancers, and a long tail of other cancers. Interestingly, next generation sequencing here allows for testing of simultaneously multiple alterations. And other methods like FISH are used. FISH is highly sensitive, but it requires technical expertise. And immunohistochemistry here lacks sensitivity and specificity for routine clinical use, but it is easily accessible. Since a vast majority of genomic rearrangements occur in the introns, we need to sequence introns. Introns tend to be much larger than exons, so we must sequence more. Introns tend to contain repetitive sequences. Again, it is very hard to map and thus difficult to sequence, and these introns are variable from gene to gene. Again, as I said earlier, the preferred methodology is next generation sequencing. Here we need to understand there are two methods for DNA-based and next generation sequencing testing. DNA-based next generation sequencing testing and RNA-based next generation sequencing testing. As I said earlier, next generation sequencing testing allows for testing for multiple alterations simultaneously. DNA is an option here, but some NTRK1 or NTRK3 fusions may not be detected using the DNA-based next-generation sequencing testing. RNA-based NGS is the preferred option for fusion detection because this can detect additional gene fusions relative to a DNA-based next-generation sequencing testing method. Again, what is RNA-based testing? By evaluating the RNA genes regions known to be involved in fusions, one can work backwards to identify a fusion partner. We need to here only sequence exon of interest to look for unexpected adjacent sequence. RNA-based technology can directly assess whether the gene fusion is being expressed at least at the RNA level. Why is RNA-based NGS superior to DNA-based next-generation sequencing option? Because we see false negatives with DNA-based next-generation sequencing options. RNA-based approaches may overcome all these limitations. Following a review of literature on the available methods for detecting alterations, specifically the RET alterations, the ESMO Translational Research and the Precision Oncology Working Group formulated recommendations for RET testing according to malignancies to identify patients who may be candidates for selective RET inhibitor therapy. Similar guidelines also exist for NTRK fusion testing across all solid tumors. And interestingly, because sarcomas also harbor NTRK fusions, there is a specific ESMO Translational Research and ESMO Working Group guidelines for detecting NTRK fusions across all sarcomas.
In the second seminar, we are going to now focus on the available targeted therapies, approved treatments for patients with fusion-positive cancers, look at how these cancers might acquire resistance to these TKIs, and also discuss emerging next-generation therapies for these patients. And we'll start off with Dr. Dimitri.
Thank you, Alex. So you get the idea that there have been fusions we've targeted for years, CML with BCR-ABL. We're going to focus in on the newest targeted therapies that everybody needs to know about. We're going to start with TRK inhibitors. We're fortunate because we have two TRK inhibitors, larotrectinib, which was the first NTRK inhibitor and has the indication that you can read there. But basically, it's an NTRK gene fusion with no known acquired resistance mutation. You'll hear a little bit more about resistance in the second part. And then another drug called entrectinib, which again is adult and pediatric patients, just like larotrectinib, similarly NTRK fusion, etc. So you can read that there, but we have two choices for TRK inhibitors in the United States. Now it's important to see the data and how really remarkable the data are with both of these drugs. With entrectinib, there's a somewhat smaller data set, with the efficacy population, as you can see by the color scheme, being across many kinds of tumors, sarcomas, lung cancers, breast cancers, colorectal, with this magnificent waterfall plot. And that's absolutely true for larotrectinib on the right. A bit more patients, a bit longer follow-up, and absolutely spectacular waterfall plots. I call your attention to the far right of each waterfall because that is minus 100%. In other words, no evidence of active disease, complete remissions in those patients, both with larotrectinib and a few with entrectinib. So we're seeing high levels of response, and they are also durable. Admittedly, the safety is also better than anyone could have predicted. NTRK, because it's important to the nervous system, there was a concern that would NTRK drugging drugs be a problem for patients? And remarkably, the safety is really outstanding. There's a bit of what you see on the left, some occasional laboratory abnormalities, a bit of very minor side effects with the GI tract or fatigue. But honestly, these are absolutely spectacularly well-tolerated drugs in general, both larotrectinib and entrectinib. And in terms of updates, because they have such a high response rate and the responses are so durable, we will never see a placebo-controlled trial against these drugs. So things like this presented at ASCO 2022 is going to be the best we will ever have to assess how do the TRK fusion drugs compare against any kind of standard of therapy, like with chemotherapy, from before TRK fusion inhibitors were available. So this is a comparison with real-world data using as a control historical patients with those matched diseases that did not receive a TRK inhibitor. And what you can see here is that there is a suggestion of an overall survival benefit. That should not be a surprise, given the high levels of response and the durabilities of these responses. Now, one can always pick apart and criticize real-world data for a variety of technical reasons, but I think this really supports an overwhelming, rational, common-sense approach to the fact that these TRK fusion inhibitors are a new modality, highly effective and very well tolerated to treat patients with TRK fusion-positive cancers of many types. Now, this is the overall survival analysis from that ASCO poster, suggesting what we've all thought would probably be the truth if we ever were to do a randomized placebo-controlled trial, that the patients with the targeted therapy, in this case larotrectinib, compared to patients with TRK fusions receiving standard of care before any TRK fusion inhibitors were available, they're doing much better than with standards of care. So let's now move to the other new fusion target, relatively new, the RET inhibitors for RET fusions. Again, you know that RET fusions are often found in lung cancers, but more often found in thyroid cancers of many types. We see two drugs on the US market, selpercatinib and pralsetinib, both of which have somewhat similar FDA approvals in this country. They have to have a RET fusion positive detected by an FDA-approved test, generally for pralsetinib. It's a bit more loose language for selpercatinib. And admittedly, there are pediatric patients with these as well who can receive either drug. So I think that's extremely important to consider the indications, and you'll hear a bit more about moving beyond these indications in the future. These are both very highly selective drugs against RET fusions and against RET targets. We see again with RET fusion inhibitors, in this case with RET fusion positive non-small cell lung cancer or thyroid cancer, these magnificent waterfall plots that we've come to expect with highly targeted therapies in fusion-driven cancers like TRK fusions. Wonderful responses and wonderful durability both in non-small cell lung cancer or thyroid cancer. This is true both for those who were pre-treated, the darker green RET and the darker blue for the thyroid, and the treatment naive, fewer in the non-small cell lung cancer, that's the lighter green lung cancer patients, and the lighter blue thyroid cancers. So at this point, it is very important that both heavily pretreated or treatment naive patients can have benefits, although the benefits seem to be a bit more numerically common in the treatment naive cancers. And this trial, codenamed ARROW, was the study of pralsetinib in non-small cell lung cancer. This again shows you the waterfall plots that are outstanding even in the setting of prior platinum-based chemotherapy treatment on the upper right, but it's even more outstanding, as you see on the bottom, for patients who were treatment naive. So treating earlier makes good sense for patients with RET fusion non-small cell lung cancer, as you might expect. That does tend to be the case in most cancers, that if there's a fundamental driver, treating that driver should lead to better outcomes, and that's exactly what we see here. The treatment-naive patients have better waterfall plots than the prior platinum, although even in the setting of prior platinum, you see wonderful activity. The same is true with wonderful waterfall plots with fusion-positive, RET fusion-positive thyroid tumors. Lots of overall responses, highly durable. As we move towards targeting the fundamental driver of many kinds of cancers, even those that share the same driver, we see this kind of study, a basket study, that explored the tumor-agnostic efficacy of selpercatinib, a RET fusion inhibitor, in RET fusion-positive solid tumors of many types. Vivek Subbiah presented this at ASCO 2022. And you'll see on the right the many different types of cancers that were tested here, with a somewhat predominance in this study of pancreatic and colon cancers. Remember, for this study, patients with thyroid cancer or non-small cell lung cancer were not included because we already knew this drug worked in them. And what we saw here was an overall response rate in this basket tumor agnostic study of 44%, including a low number of complete responders, but many more partial responders. And the efficacy was quite impressive in pancreatic carcinoma even, as well as colon and others like breast and sarcomas. So it is important to keep in mind RET fusions in other types of cancers besides non-small cell lung cancer and thyroid. These tumor responses are seen here for, again, the waterfall plots, and the duration of treatment. So the duration of benefit for these patients was also quite impressive. The study remains ongoing. Many patients are still on the study, but it is the new direction that we've come to expect from many types of therapies that are going to be tumor agnostic, such as the very first tumor agnostic approval for the NTRK fusions with a targeted therapy, or the very, very first tumor agnostic approval with immunotherapy for MSI-high patients with pembrolizumab. And just as with non-small cell lung cancer, just as with thyroid, the adverse events in the basket study were very, very tolerable with the RET fusion inhibitors. You see some laboratory abnormalities, you see a bit of hypertension, but generally very low grade, and a few other things that you'll see on this slide, nothing compared to some of the toxic combination chemotherapies that we as oncologists were trained to give many years ago. So this is a very tolerable option for patients with this fusion driver. And the same can be said for pralsetinib. There's more limited data to some extent with pralsetinib, but this has also been presented. And again, overall tumor responses show very nice waterfall plots and a very nice duration of these responses and duration on study drug treatment with pralsetinib in basket studies. So beyond this, there are many, many other strategies to move an effective therapy forward that we all know in oncology. Moving something earlier in the neoadjuvant setting is the ultimate early approach to try to shrink things before you approach them surgically. But even before you do that, you can move to what's outlined in red here, a study after surgery or radiation. So you're trying to assess the potential for adjuvant therapy earlier, earlier, earlier. Generally, again, as you've seen with the no prior therapy non-small cell lung cancer or thyroid patients, patients do tend to do better in the earlier stages of treatment. So this is a new direction that's being taken with several of the RET inhibitors in clinical trials. On this slide, selpercatinib is identified primarily.
Thanks, George. And in the next section, having heard about the available first generation or early generation TKIs, if you will, for fusion-positive cancers, Dr. Sabaya is going to lead us through the various mechanisms by which these cancers might acquire resistance to therapy. Vivek?
So what are the mechanisms of acquired resistance to kinase inhibitors across cancers? Again, as we all know, protein tyrosine kinase in our targeted cancer therapies are subject to acquired resistance. Besides activation of alternative bypass mechanisms, a mechanism is secondary to on-target mutations that interfere with drug binding, and identifying and characterizing these resistance mechanisms, discovering new drugs, and translating the drugs to clinic to overcome these resistance mechanisms are very critical for improving our patient outcomes. So what are the broad mechanisms of resistance one can think of? Like one is, broadly, we can think about de novo resistance and acquired resistance. And in acquired resistance, we can think about on-target resistance and off-target resistance. And as you can see here in this figure, mutations in the drug target that impact the drug binding, what we call as on-target drug resistance. And there are other mechanisms of resistance beyond on-target, what we call as, I would say, phone-a-friend, where there can be a bypass signaling for the cancer for the cancer pathways. Again, my colleague here, Alex Dillon and colleagues, recently published elegantly the key mechanisms of primary and acquired resistance to selective RET inhibitor therapy across multiple tumors, and they showed that many of these mechanisms of resistance are overlapping. And what we see is that de novo and acquired resistance mechanisms to tyrosine kinases like NTRK or RET have been observed in clinic. And we had multi-kinase therapies for selective RET before the advent of selective RET inhibitors like cabozantinib and vanretinib, specifically for RET. And the response to these multi-kinase inhibitors were low, partially because of the incomplete suppression of the oncogene RET kinase. And interestingly, the gatekeeper mutations in the RET domain were resistant to vanretinib, cabozantinib, lenvatinib, among others. Pralsetinib and selpercatinib overcame these gatekeeper alterations. And as you can see here, acquired resistance mutations for the NTRK A, B, and C are paralogs of other mutations. Again, many of these acquired on-target mutations interfere with the way the drug binds specific tyrosine kinase inhibitors, the new ones like selpercatinib or pralsetinib specifically for RET, circumvent the resistance of gatekeeper mutations. However, these selective RET inhibitors and NTRK inhibitors face new challenges by non-gatekeeper resistant sites. In the laboratory screening, we call them the solvent front alterations. For RET inhibitors, pralsetinib and selpercatinib, it's specifically the G10C, S, and R at the C lobe solvent front, and the Y806 CNN mutations at the hinge site and the roof site as well. Again, all the mutations that are resistant to selpercatinib are resistant to pralsetinib as well. And the most substantial resistance is on the C lobe in the G10 solvent front. And we also have seen MET amplification, and my colleague Alex Drillen and colleagues have reported that patients who acquire resistance by CMET amplification can be concurrently targeted with a MET inhibitor concurrently with a RET inhibitor, and showing that when tumor is a rumor in acquired resistance, tissue is an issue. And they elegantly showed that these bypass mechanisms can be concurrently targeted by a selective MET targeted therapy. We and others have observed NTRK fusions as a resistance mechanism to selective RET inhibitor therapy. And moreover, we've also seen a MAP kinase pathway activating events that are polyclonal within the same patient. Again, these events can occur alone or in a combined fashion in other patients. Similar patterns are being observed in other kinase fusions like ALK, ROS1, and TRK. And a new generation of superior inhibitors are evolving and being discovered as we discover these oncogene acquired resistance mechanisms.
Thanks, Dr. Sabaya. And with that introduction to acquired resistance, this last section will touch on what you can do in the face of on-target or kinase domain-mediated resistance. So we'll start off with the overarching principle that there are new agents that are currently in clinical trials. But remember that whenever possible, if you resequence your patient's cancer, you are looking for these acquired kinase domain mutations as a way of matching patients to new therapies. And if you clearly find another mechanism like bypass resistance, that these single agent next-gen treatments may not be the best fit for your patients. What are some of these therapies? We're going to start with NTRK fusions. And here you'll see two different drugs that are next-generation TRK inhibitors, repotrectinib, which is also an inhibitor of ROS1, and selitrectinib, which is a selective next-generation inhibitor of TRK. These were designed in a very intelligent fashion because what happens with the mutations is that, as you can see in the diagram, they put up blockages that prevent the binding of early generation agents like larotrectinib and entrectinib. And these molecules were designed to be smaller drugs or smaller moieties that zip past the blockage and re-engage the ATP binding domain and shut down oncogenic signaling. You'll see here proof that these drugs are active in vitro and in vivo as well, not shown on this slide. But the drugs that we spoke about, selitrectinib, that's LOXO-195 on the far right, and repotrectinib, TPX-0005, also on the far right. And you'll see that compared to earlier generation agents like larotrectinib that's in the middle, that we see increased activity in the dark blue boxes with lower IC50s for many of these acquired kinase domain mutations in NTRK1, NTRK2, or NTRK3 that Dr. Subbiah discussed in the prior section. This is an example of these next generation treatments working. So on the far right, I'll have you focus your attention on the PET and CT scans of two different patients. These were NTRK fusion positive cancers, an adult patient above and a pediatric patient below. These patients developed acquired resistance to an early generation TRK inhibitor, then went on to LOXO-195, also called selitrectinib, and as you can see, had a very nice response to therapy. And as I mentioned, this treatment and repotrectinib are both in clinical trials for your patients and are available therapies. In fact, repotrectinib already has breakthrough designation from the FDA for the treatment of patients with NTRK fusion positive cancers. So how might we use these therapies? Here you see a timeline where a patient with an NTRK fusion positive cancer starts a first generation agent like entrectinib or larotrectinib. At the onset of progression, we always look to see if progression is in a defined area or region, meaning solitary site or oligoprogression. And often in that case, we might employ techniques like local therapy, radiation to get rid of the growing clones. I always favor biopsying one of these areas to identify the potential mechanism of resistance. And if on the biopsy you find one of these mutations, then you have a next generation therapy in your back pocket for the future after much more widespread progression on therapy. Of course, if you do have widespread progression at the onset and you have the appropriate mutation or you don't find bypass resistance on repeat sequencing, then considering a next generation agent like repotrectinib or selitrectinib is a good next step. Now, before we end, a brief mention that this is a strategy that applies to other fusions as well, including RET fusions. And you've heard from Dr. Subbiah that certainly with selpercatinib and pralsetinib, we've seen the acquisition of RET mutations that abrogate drug binding. And we have newer drugs that are listed here like LOXO-260 or HMO6, which have been similarly designed with activity against these mutations. And these clinical trials are ongoing at multiple centers around the world. All right, and now we come to the discussion portion of today's session, and we're going to go through a number of points that were discussed during the didactics earlier on. The first question for George or Vivek is it often an issue that people don't know what a real fusion is? We certainly know that there are reports where you might have a fusion of uncertain significance. So is that something that you encounter in your practice? And what do you advise other practitioners that ask you this question?
Well, if I could start, and then I'll pass it to Vivek. I think that is a big issue, depending on how the molecular test is reported to the clinician. We have an internal academic molecular test that reported rearrangement, let's say. And the question was, well, was that rearrangement really translated into a fusion protein? Did it mean something for that cancer? And we went back and they said, we can't be sure. We think so, but maybe not. So I do think this is where an interaction with whatever lab is doing the molecular testing is really key. And it's where the RNA testing does have an advantage, because there it will be clear, here's gene 1, here's gene 2, the RNA shows them put together, and the part of the gene that has the enzyme in it is actually wholly entrenched in that fusion. That gives you the security of knowing that fusion is really there and the protein is an oncogenic kinase chimera, like the old mythological creature. It actually can fly on its own. So I do think that's something that most doctors want to see very clearly in the molecular report. And I know that not all molecular reports are clear on that. Some just say rearrangement, can't tell. Others will specifically say, we don't see the kinase portion rearranged, so it is not a fusion. And Vivek, I don't know what your experience has been in your reports, or Alex at Memorial Sloan Kettering.
No, I think we have a similar experience, in terms of detecting kinase fusions. I think we have a similar experience, and the reports, many times we call and talk to a pathologist to make sure that these are these are seen, and sometimes we ask even to get a liquid biopsy to confirm that, because as we know, ctDNA testing is an option for NGS as well. I don't think so we discussed about ctDNA, but ctDNA, as we all know, is specific but not sensitive, and so sometimes we do a ctDNA to look for these fusions.
And just to cap that off, this is certainly something that's not uncommon. And sometimes even in reports where you think that in the top line analysis, you might see a fusion that looks familiar, I've often gone into the fine print and seen the company mention, well, it's not clear that this is a real event. So that dialogue that you mentioned, George, is really important. Plus, the confirmatory assays to really make sure that you're dealing with a true event.
Yeah, I think that's really important, because otherwise a doctor could get a very bad first impression. If they get an ambiguous report and they put a patient on one of these drugs and it doesn't work, they are at risk of saying, oh, these drugs don't work. What are those guys talking about? But actually, it's probably more a failure of diagnostics than the drug per se, if it doesn't have a resistance mutation. That's why, for example, for the NTRK fusions, the FDA specifically said a TRK fusion that doesn't have a known resistance mutation. I thought that was really a forward-thinking approval language on their part.
Oh, absolutely. I completely agree. And it's important also to distinguish, between fusions and mutations. I think, many of the oncologists, when we get the reports, or even, when we review the history of prior treatments, sometimes they may confuse, fusions and mutations as similar. For NTRK genes, fusions are activating and predictive of response to targeted therapy. For NTRK genes, mutations do not appear to be the driver oncogenic event. I think that is one thing key. We need to drill down upon our colleagues, that for NTRK, fusions are activating and predicting of response, and gene mutations do not appear to be oncogenic driver. For RET, the fusions are activating and predictive of response to targeted therapy from non-small cell lung cancer, thyroid cancer, and also in a histology agnostic manner across all cancers. Mutations, both germline and sporadic, appear to be oncogenic drivers, specifically in medullary thyroid cancer. Again, it is important to recognize the difference between mutations and fusions, for purposes of clinical care.
I think that's really important, because a lot of doctors will get a molecular report, they'll see an NTRK mutation, they'll get all excited, and then they'll read the print about this has no therapeutic validity because none of the fusion inhibitors inhibit the point mutations with NTRK. So I do think that's key.
Yeah, that's right. And it also applies to other situations like ROS1, where you're really looking for a fusion and not a mutation that doesn't drive oncogenesis. But the other layer here is what we discussed, that of course, when you develop resistance to a first-generation agent, that you do see acquired mutations on top of a fusion. So we should just make sure that we have that distinction. But perhaps let's use this moment to pivot to what we think are the best tests for finding these fusions. Vivek, you talked about a number of things earlier on, and then you also recently mentioned ctDNA. What's your approach to optimizing the likelihood of finding one of these fusions in the clinic?
Absolutely. Thank you, Alex, for the question. Testing for TRK fusions across all solid tumors is important, especially we wouldn't be testing for just TRK fusions. We want to see, look for all alterations. Specifically for malignancies with high TRK fusion prevalence, such as MASC or infantile fibrosarcoma. And the preferred test for fusion detection for NTRK and RET is RNA-based next generation sequencing technology. There are of course DNA-based NGS and RNA-based NGS. DNA-based NGS is an option, but this clearly misses out some NTRK1 and NTRK3 fusions which may not be detected. Again, also important to note liquid biopsies like ctDNA. It is definitely an option for next generation sequencing, but sensitivity can be an issue. So it is important to know that liquid biopsy ctDNA is specific but not sensitive. If the ctDNA is negative for an oncogenic driver or undetectable in liquid biopsy, tissue is an issue. We need to perform tumor-based next generation sequencing panel, preferably RNA-based, and DNA-based NGS is an option as well. Other options that are available clinically, right, to us are immunohistochemistry. It lacks sensitivity and specificity for routine clinical use, but it is easily accessible. Again, when several times in the clinic we see patient is positive or negative for IHC, and they would want us to start some treatment, but here IHC lacks both sensitivity and specificity. In this case, we still need to do an NGS-based testing to confirm the presence of these activating fusions. FISH is highly sensitive, but it requires technical expertise. And RT-PCR is also able to identify fusion partners, but cannot detect unknown fusion partners. And again, very poor preservation of the tumor sample reduces sensitivity, and there are quality issues in terms of doing RT-PCR. So again, to drill down that here for testing and detecting fusions, RNA-based NGS is the preferred option for both NTRK and RET fusions, and of course all other fusions as well.
So George, let's flesh this out a little bit more. So I agree that I think that the best approach when you have coverage is to do NGS that is both DNA and RNA based. But there are other issues like people who are in different practice environments where maybe there's not coverage. Also, you get into the weeds of, while there may be billable cancers, it might be more difficult to sequence a different histology apart from lung. Well, what are your thoughts on testing relative to these different barriers?
I think these are the practical problems that community docs are encountering all the time. I think Medicare made a big move forward a few years ago when they said for metastatic solid tumors, next generation sequencing will be covered for beneficiaries, but it's still confusing because Medicare is a patchwork quilt of different organizations that administrate Medicare rules across the country. So I think it's really a problem, and I can't say that we've solved it either. Even within our group, of the sarcoma group, we have different opinions amongst our experts about how to use sequencing, when to look for things. In many ways, I'm very jealous of our non-small cell lung cancer colleagues, because their non-small cell lung cancer has really carved the path forward, right? Comprehensive molecular testing the first time out with multiple genes, with really best technology, has been shown and presented at ASCO as a cost-effective, patient-friendly way to use the tissue wisely and to get to the diagnosis as fast as possible. And I think that's not been true in most other cancers. At least in lung cancer, you have to look for EGFR, ROS1, ALK, RET, BRAF, the list goes on and on and on. So non-small cell lung goes after this. Most other cancer types still are in the dark ages of maybe we should look at these 2 or 3 genes. And I'll give you my nightmare scenario. We had a patient who was referred from another site, a big academic hospital, had molecular testing with an older panel. I'm talking only 5 years old. And that was negative for any pathogenic driver. So the patient came in, had a malignant schwannoma, also known as a malignant peripheral nerve sheath tumor. got chemotherapy, had a little bit of benefit, started to progress, got another chemotherapy, little benefit, but not much, and then just started to progress all, with all the barn door was blown open, the cancer was moving very, very quickly. So I looked at the original molecular testing, and it was one of these academic panels of, let's say, 80 genes. And I said, you know what? How do I know how well they even looked for a fusion? And of course, you know where I'm going to go with this. We actually sent it out to another lab, which we had more faith in, more comprehensive. And ridiculously, we found a TRK fusion. So we put the patient on the TRK fusion inhibitor, first generation larotrectinib. Patient did great. For about a year, resistance kicked in. Patient was not able to get to the other drug fast enough. Complications from where the cancer was in the lung got in the way of that, and the patient passed away from the disease. But in retrospect, I always worry, what would that patient have done had we been able to really identify that sooner and had not given mutagenic chemotherapy over the time that the patient was getting chemotherapy? That to me is why patients where if we could identify who's at the best chance of having a TRK fusion, we should do that right away. And I think that's important. In our world of sarcomas, we have 200 different kinds of sarcomas. We've really tried to identify, are there kinds of sarcomas where you really don't need the testing? So we identified liposarcomas, which have MDM2 amplification and a specific chromosomal amplification, chromosome 12. But then the French sarcoma group comes out and said, we found 3 liposarcomas of that type that have TRK fusions. And they drugged them and it worked. The TRK fusion was a driver. So at least in sarcomas, I'm really feeling that it makes sense to screen them all, except if you've got a known mutagenic driver like a KIT mutation in GIST. Those you don't need a TRK fusion. You're not going to look for it because you're not going to find it. But even in the GISTs where we don't have a driver, we look now very fast for TRK fusions because that's where they're going to be enriched. That's all I can say, but you can't treat the patient unless you have the best diagnosis. And these days, molecular testing is the best diagnosis. And it's moving very quickly. I don't think all the commercial labs or the academic labs are really making it easy for community doctors or even academic doctors to figure out how best to diagnose their patients. We're not pathologists, we're oncologists.
Absolutely. Well said, George. I think, even in lung cancer, and, you mentioned older panels and newer panels, I think it's important to distinguish between a mutation panel and a fusion panel. Again, many of the centers, small centers, they may just test for a mutation panel and say that, it's negative. It doesn't mean that, they test for fusions. You really need to look into the report and see if they tested for fusions. Again, you said that you were jealous of, lung cancer again, but unfortunately, there are, so many reports, from the community that even in lung cancer patients, around, the figure is 30 to 40% of patients are not being tested appropriately, right? I think maybe I should ask Alex, this question. So again, we frequently find patients, for instance, let me share an experience with our patient, a 50-year-old female, former very light smoker, presented with cough, found to have metastatic lung cancer, and the EGFR, ALK, ROS1, BRAF are all negative. But in this case, PD-L1 was positive by IHC, and then we performed an RNA-based NGS panel. It turned out to have a KIF5B RET fusion. So here, we were discussing in our, treatment planning meeting and tumor board, what would the PD-L1 positivity by IHC mean in the context of a RET fusion. I think, you probably encountered that almost every week in your setting. Do you want to talk about that, Alex?
Oh yeah, absolutely. And it brings up a good point that in the way that we think about these fusion-positive cancers, we have to also consider what happens with other systemic therapies. And we know that a lot of these cancers with fusions tend to be very genomically naive. They may not have a lot of neoantigens on the cell surface. And so while they can express PD-L1 at a high level, a certain proportion of them, what we've seen in practice, and we've published a lot of this, is that the likelihood of response to single-agent immunotherapy is low. And so if you look at the hierarchy of different therapies relative to benefit, really starting with the targeted therapy is the best way to go. And I think that talking about cases and how active these treatments are, also share that we had a 76-year-old woman also with a lung cancer who had widely metastatic disease to bone, liver, etc. She was found to have an NTRK fusion, thankfully, and she actually refused chemotherapy. Which in lung cancer, a platinum doublet can be highly active, but now we know if you look at the registrational data for drugs like larotrectinib or entrectinib, that the outcomes with targeted therapy certainly beat chemotherapy. And so she, unsurprisingly, had a dramatic response to therapy and has been on it for 4 years and is still ongoing and hasn't seen chemotherapy yet. And it just highlights really how important it is to do the testing to find these alterations, because it helps you find the best first therapy that can result in really durable disease control.
Yeah, I think that's definitely true in lung cancer. I have to bring up the case of colon cancer, where the TRK fusions are often co-found with an MSI high status. And that brings up the wonderful opportunity to say, okay, do I start with the TRK fusion inhibitor drug, or do I start with immunotherapy? Because the MSI high types of cancers do tend to have remarkable benefit with immunotherapy. And the fact there is, I don't think we have data one way or the other that one is better than the other, but it gives you two wonderful tools to treat those patients with. So I think it sounds like a bad thing, but in many ways it's up to the physician then and the patient to say, okay, I'd rather have the TRK fusion drug because I don't want to risk the immunotherapy toxicities, or I'd rather have the immunotherapy first because it cured Jimmy Carter or something. Whatever reason they come up with is a patient-doctor shared decision with two wonderful treatment options. That seems to be unique, though, in colorectal cancer. I have not seen that with anything else. Is that your experience?
Yeah, it's a good situation to keep in mind, because it does happen. And I will point out that those cancers are also enriched for other fusions and not just NTRK. So you might see a ROS1 fusion, for example, or a RET fusion. We've seen that in our hands. But many of the other cancers do tend to be less genomically complex, low TMB, etc. Well, perhaps at this point, Vivek, why don't you share your experiences with the clinical trials of next generation therapies? Are they really working well? And in what context do you consider these relative to the sequencing that you perform on progression if you do repeat sequencing?
Yeah, absolutely. I think we have several next generation TRK tyrosine kinases that can address on-target resistance to early generation TRK tyrosine kinase inhibitors. Again, the second generation TRK inhibitors are being increasingly investigated in clinical trials for patients who have developed acquired resistance to early generation TRK inhibitors. The important thing is that the first thing is, I would advise and recommend all community colleagues to first test for these RET and NTRK fusions. And we have two, not one, but two NTRK inhibitor therapies for NTRK fusion positive cancers, and we have seen dramatic responses. And although after some time they do acquire resistance mechanisms. So what are the second generation selective NTRK inhibitors available, right? So I think we have selitrectinib. It's a TRK selective inhibitor. We have repotrectinib, which is a TRK selective inhibitor. It also inhibits ROS1, and the phase 1-2 trials are ongoing. And then there is another drug, the taletrectinib, which is also a TRK and a ROS1 inhibitor. And there are two other drugs with no names, the SIM1803-1A, which is a combined TRK and ROS1 inhibitor, and the PBI-200, which is a TRK selective inhibitor. Again, all these agents are in phase 1, early phase 1, phase 2 studies. And it is key, to identify patients for these next generation selective RET inhibitors. Again, recently there was data from the selitrectinib study showing patients with who developed acquired resistance from the prior first generation drugs larotrectinib and entrectinib. And in fact, they showed that around an objective response rate of around 45%. And all patients who acquired solvent front gatekeeper and the XDFG mutation, all of them had a response to this therapy. Again, the key is, first thing is we should know that TRK inhibitors are active, result in durable disease control in TRK fusion positive cancers, regardless of prior therapy, regardless of fusion partner. And we have two drugs, entrectinib and larotrectinib, approved for both adult and pediatric patients who have an NTRK gene fusion positive. Resistance to NTRK inhibitor therapy can develop. Next generation the tyrosine kinases can definitely re-establish disease control. And here the key is when tumor is a rumor with acquired resistance mechanisms, we say tissue is the issue, and molecular profiling and can help direct treatment sequencing. And all these drugs, as Dr. Dimitri mentioned earlier, are very well tolerated, again, compared to what the chemotherapies that we used to give to these patients. And they have a very low rate of dose modification and drug discontinuation as well. And of course, these drugs do have a unique adverse event profile, like dizziness, LFT elevations, and they are definitely outlined in the labels and that require monitoring in the clinic. Again, these are drugs, the RET inhibitors and NTRK inhibitors, show the power of precision oncology. Again, we've seen dramatic responses in patients who have a performance status will be declining in clinic, and we start these drugs and they have dramatic responses. So again, the key is testing for these alterations, identifying these alterations, and offering these patients the right treatment at the right time.
Thanks, Vivek. We're going to wrap up in a second, but one quick question for George. Have you had issues with repeat sequencing to identify acquired resistance?
We have not, but let's be honest, I'm at an academic center where billing is far from our first order of business. We are fortunate to have funds that can support that, and it's sort of a 1960s environment. We do what's best for patients, and it's a privilege to work at an academic center like that. I will say that is a big issue. I think how we manage this question as responsible stewards of healthcare resources is important. And I know our pathologists are working on this too. It'd be nice to have a cheap immunohistochemistry assay, let's say, that could identify the target that starts to glow bright green or something if you have a solvent front mutation, something like that. I think it's an issue. I'm really confident too that the costs of testing are going down. They're going to go down further. They're going to be more of a commodity play with high quality. And I'm thrilled about that. Like, look, let's be honest. We all have iPads that if we had bought them in the 1960s, not that they existed, they would have been multiple millions of dollars. So technology has shown that technology improves, things get cheaper and they get better. And I think that's going to be true for sequencing as well. So that's my hope anyways. Maybe I'm just an optimist. How about New York? You guys have a population there that's pretty big. Do you see that as a problem?
Not in our institution. I think we share sort of a similar environment, but I've certainly heard that people in the community have struggled trying to get repeat sequencing. And thankfully, since there are multiple stakeholders in drug development, we've seen some companies actually offer repeat sequencing to better identify patients for these next generation trials. But I don't think that's enough, and that we need to get improved coverage across the board.
Yeah, but I think that's really a good point relative to what Vivek said. These TRK fusion patients are rare enough to start with, and then the ones who develop resistance are a subset of those, because many of those go on for years on the first generation drug. So that's why the second generation drug trials in phase 1, phase 2 are taking so long, because they're really hard to accrue. But that's why I do think it's important to at least be aware of it as a physician, because there are resources to help patients access the trials. I think that's absolutely key.
Well, that was certainly a wonderful session. Thanks very much, George and Vivek, for your commentary today.
This activity is certified by PVI, Peer Review Institute for Medical Education. Remember to download the slides and practice aids